Hello. A very warm welcome to all of us for this meeting. Thank you so much for joining us for this webinar. Our presence here, each one of us, is a testament to our commitment to the fight against antimicrobial resistance. Of course, during the World AMR Awareness Week, a lot of activities take place all over. The idea is to create awareness, and that for each one of us who will participate in this meetings or these engagements, we will take away with us something that will help us in our fight against antimicrobial resistance. At the Ghana College of Pharmacists, we are particularly interested in AMR, not only because of our mandate to train specialists and also contribute to health policy, but also because we understand that AMR affects each one of us on an individual level, perhaps more than we realize. To contribute our quota to creating awareness on AMR, we have lined up professionals and practitioners who are passionate about AMR on a daily basis in their work. They are going to share with us some of the things we can do, bring ideas to the table, how we can work together as professionals in our individual capacities to help in the fight against AMR. So I will urge each one of us to stay present during all the presentations and the discussions, and let us contribute. There is something that you know somebody doesn't, which may help us, all of us, as we work tirelessly and aim at battling AMR together. So once again, welcome. When we are closing, I'll share with you some of the other sessions that we have lined up, but this is only the first in our series. And so welcome, and may we all have a really beneficial time. Thank you. If I am right, I have to introduce our speaker as well. And so to give us a brief presentation, so let me just tell you how this program will go. We will have some presentations from our excellent experts, brief presentations from each of them. And then when we have finished, we will open the floor. So we want it to be engaging. We want it to be lively. So take note of all your comments and your questions, any clarification that you may need. And then once they finish their presentations, you bring them out. Each one of them is ready to give you a response. And let all of us, it's not only questions that we are looking for, comments, how you think we can do better, ways that we may have forgotten, and let's all bring our thoughts together. And so to speak to us on the role of healthcare professionals in the antimicrobial resistance battle, looking at the perspective of the pharmacist, we have Pharmacist Saviour Yevutsey. I will ask that Pharmacist Yevutsey will do a brief introduction of himself, because in addition to being a pharmacist, he wears quite a number of hats, which make AMR something that is perhaps a pet topic for him. So I'll hand over. Pharmacist Saviour Yevutsey, please take over and take us through, after your brief introduction of yourself, the perspective of the pharmacist in our fight against antimicrobial resistance. Thank you.
Thank you very much, our rector, and good evening to everybody. As rightly said, my name is Saviour Yevutsey. I am currently the National Coordinator for Antimicrobial Resistance National Action Plan Implementation in the One Health approach. I'm also in charge of drug policy at the Ministry of Health. My role as the coordinator for AMR is a challenging one. As you all are aware that AMR, as rightly said, this is a battle we have to fight together. And this is the Awareness Week creation. And all of us need to be around and trumpet the message in our various communities, even in our hospitals, as we can see reports coming in on the platform, AMR platform. WHO has celebrated it, and all over there is celebration going on, and awareness creation is ongoing. Great. So briefly, I just want to take you through the AMR situation in Ghana briefly, and then the policy that is what we are pursuing, and then the governance structure that we have for the implementation of these policies, and then the perspective of the pharmacist in ensuring that awareness is created among the populace in Ghana. As you are aware, antimicrobial resistance is a silent pandemic which is killing people slowly, and now it is even loudly. I just want to share some reports from a work done by a group looking at the deaths in 2019 in Ghana. And it was estimated that AMR death in Ghana is higher than deaths from neglected tropical diseases, malaria, neoplasms, maternal and neonatal disorders, HIV, AIDS, sexually transmitted diseases, and diabetes and kidney diseases. This is alarming. We always say that malaria is the trouble causer, but data coming out is showing that AMR is the one causing the problem for us. Currently, as part of our National Action Plan implementation, we have 5 pathogens that we have focused our lens on. And from that work in 2019 shows that one of them, Klebsiella pneumoniae, caused estimated death of 4,600. And that is the highest death when we look at the 5 pathogens we are tracking. Streptococcus pneumoniae contributed about 4,200 deaths. Staph aureus, 3,700. E. coli, which is found everywhere, is 3,600. Pseudomonas aeruginosa caused 1,600 deaths. This should tell us that as pharmacists or healthcare professionals, we need to put our eyes on these pathogens because they can cause havoc for us. And as you are aware, these bacteria are responsible for lower respiratory tract infections and all related infections in the thorax, bloodstream infections, and peritoneal and intra-abdominal infections. So, any hospital where we practice, we need to put our eyes on these bacteria or these pathogens because the data we have from the bloodstream infections that we submitted to last 2 years shows a significant resistance to some of these bacteria, especially Klebsiella pneumoniae and E. coli. Ghana is not standing aloof. Since 2017, we have developed a national policy and its national action plan with the overall goal of improve and sustain the health of the population, as well as enhancing the food security, ensuring responsible use and access to safe, effective, and affordable antimicrobial of good quality, to slow the emergence of resistant microbes and prevent the spread of resistant infections in One Health approach. We are not doing this alone as humans. We are doing it with animal health and the environment, because the animals also use the same antibiotics, even the cocktail of those antibiotics that we use. And even environment, the repository of all the waste products, is also not left out. That is why all the three sectors have come together to fight this menace. The policy that is guiding us has five strategic areas. And the first one, strategic objective one, talks about awareness and understanding of antimicrobial resistance. And this is what we are doing today, trying to raise awareness among even the healthcare professionals, because we actually handle the medicines and handle the patients. So we need to create awareness among ourselves, and then we move into the community. The other one talks about strengthening knowledge and evidence through surveillance, monitoring of resistance, bacteria or pathogens, and then the antimicrobial use in our healthcare settings. We are also called upon to reduce the incidence of infections as part of the strategic objectives of the NAP, and then optimize the use of antimicrobials, microbial agents. The last one is to build economic case for sustainable investment into antimicrobials. This is where we call upon scientists to develop more drugs, because the pipeline, as is being said, is very, very dry. The pipeline for development of antimicrobials is very, very dry. So it is the old antimicrobial that we continue to use, and we are even combining them now to be able to overcome this. As you can see, we have the policy and then the National Action Plan. And I would want to say that the National Action Plan has expired. We have done the assessment of implementation, and the report is ready for sharing. Very soon, there will be a big stakeholder meeting for us to share the report. In implementing all this, we have this governance structure where we have interministerial committee made up of the 4 sector ministries. That's the Ministry of Food and Agriculture, Ministry of Food, Ministry of Fisheries and Aquaculture Development, Ministry of Environment, and Ministry of Health. Ministry of Health is the coordinating ministry, and that's where the AMR Secretariat is located, and I am the head. And we also have partners on board who are supporting us greatly in the fight against AMR. And we also have various technical working groups. And I strongly believe there are people online now who are members of some of these technical working groups, contributing their quota in the fight against AMR. The pharmacists, all healthcare professionals have a role to play. Even the cleaner at the hospital, the watchman, the security man at the gate has a role to play. Therefore, the pharmacist, who is also a custodian of the medicines, has a key role to play, and our role is indispensable in combating and preventing infectious diseases, especially as antibiotic and vaccines regimens become increasingly complex due to constantly evolving epidemiology of infections. As a community pharmacist, which we always say is a gateway practitioner, we have that unique opportunity to intervene and prevent an unnecessary antibiotic use at the community level. And we all know that this abuse, overuse of antibiotics is one of the main causes of resistant development in the microbes. So the community pharmacist, we have a role. We shouldn't allow our clients to demand so much on antibiotics from us, and we need to apply our professional judgment in treating our clients. As a pharmacist working in the community and even at the hospital level, we need to promote antibiotic stewardship programs in our facilities. And one of the way is to have pharmacist-directed antibiotic stewardship programs in our facilities. This is where we mean training of infectious disease trained clinical pharmacists for our facilities to champion AMS. And I think it's time for us to have pharmacists who have infectious disease specialists, consultants, to be able to champion the cause of AMS in our facilities. We should be conversant as pharmacists with the criteria for selecting appropriate antibiotics for our clients. For instance, whether the organisms we are trying to treat in the patient is a gram-positive or a gram-negative organism, because this is one of the things we consider in selecting antibiotic for our patient. We should also be looking at the organism's susceptibility to a particular agent. So this is the role of a pharmacist to look at. We should also be looking at the site of the infections. The site of infection will determine the type of antibiotic you will select. If the blood-brain barrier effect of the medicine need to be considered, you have to consider it because of the site of infection. Its protein binding capacity, you have to consider that, and lipid solubility and the molecular weight of the drug. We need to know all these technical aspects of our work in selection of antibiotics for our patients. We also need to focus on the patient factors, especially looking at the disease condition or the condition of the health condition of the patient, the renal and the hepatic nature, the age and the sex, the pregnancy status of the patient, the woman, the lactation, and the immune system of the patient we need to consider in selecting the appropriate antibiotic for our clients. Some of the antibiotics are equally have very bad profile side effects. For instance, chloramphenicol and aminoglycosides. We need to look at that properly before we select. And then the cost of the therapy. Some of the drugs are so expensive. So as a pharmacist, to ensure compliance and adherence, we need to look at the cost of the medications we select for our clients at the facility level. The pharmacist as an educator has a role to play, very, very vital, in curbing antibiotic resistance. We need to address the patient, the clinician's concerns as pharmacists about the antibiotics and the vaccines that we recommend for our clients. You also know that there are some parents that are hesitant to vaccinate their kids due to concerns about side effects, both real and imagined. Sometimes they just imagine. With a pharmacist, you have the acumen, the capabilities to help patients separate fact from fiction about immunizations. We also have to look at education regarding infection control practices in our settings. And this is a very crucial role for all of us, wherever we find ourselves, at the community level, at the hospital level, in our churches and everywhere. The pharmacists, you have the knowledge about how to prevent infections, and we need to educate our clients on those aspects. Pharmacists may be proactive regarding educating the public about important infection control practices such as general hygiene, hand hygiene, cough etiquette, immunization, and stay home when sick. We have this knowledge. We are keeping them. We need to let them go for the appropriate intervention to be effected. So I am calling on the pharmacist to play their role in the control of the development of resistance in the country. Looking at this diagram, you ask yourself whose work? You see the microbiologist, you see the physician, you see the pharmacologist. The pharmacist is at the center. The selection of antibiotics, when the microbiologist finishes his or her work, he may not consider the other factors that we use in the selection of the antibiotics. And the pharmacist must help in this direction, and the clinicians will agree with them, and then they can all have a common goal in achieving the treatment outcome. The pharmacist also has a role as a quality assurance expert. You and I know that if we have a poor quality antibiotics, we are virtually not treating our clients or the infections. Sometimes it may even lead to substandard dosing. And we know that if you give a low substandard dose to patients who are infected, you may not achieve your results, and that can contribute to resistant developments. So the pharmacist has a big role to play in this arena. For instance, in the hospitals, we need to ensure that the sources of antibiotics are known, are places that we can vouch for. And we need to know the registrative status of these antibiotics that we procure and store in our various hospitals. We also need to look at the storage condition under which we store these drugs. And we also have the ability to educate our clients on how to store medicines, antibiotics that are mixed. For instance, when we mix amoxicillin clavulanic acid for our clients, we need to educate them to keep them under refrigeration, because literature shows us that when kept outside the fridge, after 72 hours, 50% of the active ingredient is gone. So from that, the third day going, we are just with substandard dosing. So the pharmacist has a responsibility to play in that. And the most crucial is the disinfectants and antiseptics that are used in our hospital settings. In fact, there's a research that I read last week that they've conducted in Ghana that shows that the 42 samples that were taken, disinfectants that were taken, all of them failed to kill those pathogens that we saw earlier from the hospital environment. So what are we doing to our clients? We are just, when they come to the hospital, they come and share microbes, dangerous microbes, and go away with them, because the tools we are using, the chemical we are using to kill them, are actually substandard. So pharmacists has a big role to play. And even if we have to produce some of these things in our hospital settings, it will go a long way to help fight the infectious disease. To conclude, the pharmacist is a custodian and an expert in medicine, and must play a pivotal role in combating drug resistance, and must understand how drug resistance happens at the molecular level. Collectively, we must reduce the spread of AMR bacteria in the ecosystem. Pharmacists have a role to play in areas of community education based on evidence. I end it here and wait for more questions for clarification. Thank you very much.
Thank you so much, Mr. Yevutsey, for that presentation. Indeed, you have touched on a number of things that I believe are relevant for the pharmacist and his work in the space for AMR. You've touched on education, you've touched on stewardship, you've touched on quality assurance, and you've also enlightened us on some practical things that we can do to contribute our quota to AMR. Now, I think we want to once again greet our audience and then continue with the program, and then look at our next speaker, who would be the next expert who will be speaking to us. She is a senior specialist pediatrician with almost 2 decades, 20 years of working experience with the children. And I think that promises to be very interesting. She then also doubles as the medical superintendent for Lekma Hospital. She's been with the AMR stewardship program for the past 5 years at Lekma. She's very passionate about stewardship, of course, and then she's also a lead partner with the CW Pharms, doing a lot of work. That is the Commonwealth Partnership for Antimicrobial Stewardship. She's contributed a lot in that area as well. She's a principal investigator for the SPIDA initiative on AMR. And we know that as part of all of her work and the contributions that she has made, Lekma Hospital won the Industry Alliance 2022 Stewardship Prize. And I think that is quite significant. She has also featured in a BBC Works documentary entitled Race Against Resistance, the Life and Death Struggle to Save Antibiotics. I mean, I could go on and on and on and on and on, but we want to welcome Dr. Akua Gyimah Asante to give her talk for this evening's session. Let's welcome her, and then Dr. Gyimah, you have the floor. Thank you.
Thank you very much, Brian. Good evening, everyone. With that introduction, I'll go straight to my presentation, which is the role of health professionals in the antimicrobial resistance battle. I'll look at the perspective of the medical doctor. So this will be my outline. The outline will include a short introduction. We'll look at the drivers of AMR and the role of the medical doctor. I will attempt to paint a picture of the post-antibiotic era and end with a summary. So as the first speaker, Saviour, has said, we all know AMR is a huge threat. It's one of the most serious public health threats in the 21st century. It accounts for about 700,000 deaths in Africa alone every year. And it is estimated that by 2050, there will be about 1.4 million deaths attributable to AMR if nothing is done about it. We know that WHO has declared that AMR is one of the top 10 global public health threats. And the sad thing is that it's very silent. We do not see it. It's not like malaria that you can say 10 people died from malaria. It's very difficult even to get the data for deaths that is attributable to AMR. And there's a rapid global spread of multi-resistant bacteria. And like Saviour said, the clinical pipeline of new antimicrobials is very dry. And due to the rapid nature of resistance development, the pharmaceutical companies don't find it lucrative enough to invest in the development of new antibiotics. As we all know, antimicrobial resistant bacteria can be found in humans, can be found in animals, and even the environment. And therefore, it makes sense to take a One Health approach to address the problem of AMR. Basically, what One Health approach means is a collaborative effort of multiple disciplines to attain optimal health for people, animals, and our environment. We know that human health is linked to animal health, and it's also linked to environmental health, and therefore the need for One Health approach. Now, globally, there's been effort to combat AMR, and we know that in May 2015, WHO adopted a global action plan and the member states signed to it. Ghana was one of the member states. And we also have a national action plan and a national policy, just as Saviour has enumerated. It was adapted from the WHO Global Action Plan. I will not go over the Global Action Plan because Saviour has done that. But in essence, if you look at the plan, it has 5 objectives. And basically, the goal is to ensure treatment and prevention of infectious diseases with effective and safe medicines that are quality assured and used in a responsible way and also accessible to all who need them. The objectives outlines 1, awareness creation, the need to strengthen knowledge, the need to reduce the incidence of infection, and also to optimize the use of antimicrobial medicines. And the 5th objective is to develop an economic case for sustainable investment. If you look at these objectives, you realize that they form the framework for the fight against antimicrobial resistance. And it's quite evident that healthcare workers can play a role in all 5 objectives. Other efforts, global efforts, include the launching of GLASS, the Global Antimicrobial Resistance Surveillance System. And this was established to actually support the surveillance system. And I know that Ghana is enrolled on GLASS. We have another global effort, that is the aware classification of antibiotics. And this was developed by WHO Expert Committee. And this tool is actually to support antibiotic stewardship efforts at all levels. Now, let's look at the drivers of AMR. And this knowledge is important for social and behavioral change. And of course, it informs our role as healthcare workers. AMR, we all know that AMR occurs naturally over time, usually through genetic changes. And we are also very much aware that resistance is an inevitable biological process. But one thing we should also know is that we bear the responsibility for accelerating it. And the main driver for AMR is misuse and overuse of antimicrobials. We misuse antimicrobials all the time. For example, when we use antibiotics to treat viral infections. And the overuse of antimicrobial is the main driver for antimicrobial resistance. The other drivers include lack of access to clean water, sanitation, and hygiene. And this increases the risk of infection and disease, hence the use of antibiotics. Hence the development of resistance. Now, poor infection and disease prevention and control in healthcare facilities and farms is also a driver. And we all know sometimes there's poor access to quality, affordable medicines, vaccines, and diagnostics. All these drive antimicrobial resistance. What is even worrying is the lack of awareness and knowledge. Remember, what you don't know, you cannot fight. Hence the need for awareness creation and knowledge strengthening. And also there's lack of enforcement of legislation. We all know as a country, we can buy even antibiotics over the counter, and that is a problem. Now, how can we all help? With this background knowledge, what is our role as healthcare workers, and in particular, the role of the medical doctor? Healthcare workers play a pivotal role in the fight against antimicrobial resistance. And I believe that medical doctors, as primary healthcare decision makers, are strategically placed to lead this fight. Medical doctors have a role to play in awareness creation, education, and communication. We have a role to play in responsible prescribing. I think that for antimicrobial stewardship, we can also lead antimicrobial stewardship programs in our facilities. We must also play an important role in infection prevention and control, research and development, and advocacy and collaboration. Now, for awareness creation, education, and communication, we can educate our patients wherever we find them, in the consulting rooms, in the ward, anywhere, because there's need to create awareness about antimicrobial resistance. Some patients do not even know that there's something called antimicrobial resistance. We need to abstain from antibiotics if it's not indicated, and that knowledge should be shared with our community, our clients. It's very important to disabuse the minds of our clients who believe that antibiotics are necessary for every illness. So it is up to us to educate them and tell them that for some diseases, we do not need antibiotics. The body itself will heal itself. We need to educate our clients on the importance of completing antibiotic use, and also the potential risk of inappropriate antibiotic use, including antimicrobial resistance. Now, peer-to-peer education is also an important component. As medical doctors, we have to educate our colleague doctors, our pharmacists, our nurses, medical laboratory scientists. It's important we all understand the importance of AMR and antimicrobial stewardship. We are also aware we have local guidelines, we have national guidelines, we have the standard treatment guidelines, and even some hospitals, for example, in Lekman Hospital, we do have local guidelines. Those are, we call it antibiotic man and antibiotic child. They are basically adopted from the standard treatment guidelines, and we shaped it according to our antibiogram. So we need to educate each other about these guidelines. We also need to educate our colleagues about the aware classification, the access medications, the reserve medications, the watch medications. We know that we are supposed to be using the access medications most of the time. So we need to educate each other about these and also about best practices. It's also important that we get involved in continuous medical education to stay informed about the latest developments, latest guidelines, and treatment options. We know that the healthcare is dynamic, and even more dynamic is the emerging resistance patterns. They are changing every day. And so for me, I even want to propose that AMR, AMS should be one of the mandatory topics, just like ethics, for retention and for recertification by all our regulatory bodies, including Ghana Medical and Dental Council. We should make sure that it's part of our recertification courses. The second and one important role of the medical doctor is what I call the 5 Ds. And this is diagnosis. The first one is diagnosis. Evidence-based guidelines should be used for diagnosing infections and initiating antibiotics. We know that wrong diagnosis may result in the misuse of antibiotics and inevitably the development of resistance. The second D is drug, and the most effective drug with the least adverse effects should be selected. Sometimes we start from very, third generation drugs instead of using the simple ones. Drugs should also be adjusted based upon our culture results and the facility's antibiogram. Now, our doses that we prescribe must also take into account the patient's comorbidity, the weight, and other medications to ensure optimal treatment. Duration is the fourth D, and it must be based on the current evidence-based guidelines for treatment of the infection. So if it is 5 days, we must prescribe for 5 days and educate the patient to adhere, to comply with the dosing. Now, de-escalation is also important, and the narrowest spectrum drug with clinical efficacy should be used. Drug therapy and patient response should be reviewed as often as possible. Now, I also think that doctors have a role in antimicrobial stewardship. Doctors should actively lead stewardship programs in their facilities to improve patient outcomes across the continuum of care. And this involves working collaboratively with pharmacists and other healthcare professionals to optimize antimicrobial use. Some activities of antimicrobial stewardship, I've talked about it before. It includes peer-to-peer education, awareness creation. And this awareness creation is actually an awareness campaign because it goes beyond the education that we give to our patients in the consulting rooms. This involves using social and behavior change communication strategies to optimize antimicrobial adherence. It also involves community partnerships, and that's very important. Community engagement. We need to engage the opinion leaders, our community pharmacies, our schools. Only yesterday, Lekman Hospital engaged one school, and the feedback was very encouraging. We have to encourage best practices amongst the general public, as well as even the policymakers. It's important that we engage all these people to integrate AMS messages into the activities and even in the curriculum of our schools. One other important stewardship activity is global point prevalence survey, and this can be done for inpatients as well as outpatients. And this actually gives us an idea of our consumption, antibiotic consumption pattern. We should also be engaged in antimicrobial stewardship ward rounds. We could decide we're doing it once a week or once every other week, but it should be routine. It should be integrated into our daily works. During the ward rounds, we can look at our antibiotic consumption and look at all the factors concerning our antibiotic use and see whether we are on the right path. We can also engage in backup prescription. This is a model that reserves the prescription of antibiotics until it is actually needed. If it's not needed, the patient is not put on antibiotics. So it's a model that we can share with other facilities to also engage in. Now, AMR surveillance, laboratory surveillance, I think it's critical to tackling AMR. Basically, it involves collection of data, analysis, interpretation, and dissemination of data related to AMR at the lab. And this is quite very important because it gives us quantitative data about the spread of resistant bacteria, resistant strains. It also actually informs intervention priorities and identify gaps in service delivery. We could even use that data to identify hotspots of resistant infections. And it is through this data that we can advocate for policy change concerning AMR. Now, it's also important to collaborate with other health workers in antimicrobial stewardship. And I think that is the fundamental thing that we have to do. Doctors alone cannot do AMS. We need everybody on board when it comes to antimicrobial stewardship. I also think that the doctor has a role to play in infection prevention and control. And The advent of COVID, for example, the COVID pandemic, I think exposed our deficiencies in IPC. Likewise, the Lassa fever. A lot of health workers who came into contact with a patient with Lassa fever got infected, and that exposed our deficiencies in IPC. Like Saviour has said, Ghana has IPC manual and protocols, and doctors and all health workers should adhere strictly to infection prevention and control measures to prevent the spread of infections and to reduce the reliance on antimicrobial treatments. And in that way, we can limit the emergence of resistant strains. Other infection prevention control, apart from hand hygiene, includes environmental hygiene, decontamination, and wearing of PPEs, and we must all be abreast with these protocols. Now, the doctor also has a role in research and development. I think that the doctor can contribute to research efforts by collecting, analyzing, and disseminating data on AMR. We could also participate in clinical trials. In actual fact, there are a lot of researches going on in AMR, and the medical doctor has a role to play in these researches. We could also support initiatives that are aimed at developing new antimicrobial agents or treatment strategies. Advocacy and collaboration is also very important. We must be the voice for the voiceless. And doctors and healthcare workers must advocate for policy change based on AMR surveillance data to promote responsible antibiotic use. So that is why we need to churn out data in our facilities so that we could use that as a basis for advocacy. We can advocate, we can strengthen our collaboration with the Ministry of Health. Saviour is at the Ministry of Health, and to ensure that AMR data shared are used for to inform policies, and that I know they are doing very well. Doctors can also engage in global health initiatives addressing AMR, and we can contribute our expertise to international efforts being made globally. Our skills and our expertise can be shared on the international platform. Now, I begin to shiver anytime I think of post-antibiotic era. Since the 1940s, the time frame between when an antibiotic is developed to the time when resistance occurs has shortened at an alarming rate. In fact, the statistics are alarming. And without urgent action, we are heading for a post-antibiotic era in which common infections and minor injuries can once kill again. Just imagine a world where there is lack of protection for people with weakened immunity, for example, cancer patients, people who are on foreign objects and therefore would need some antibiotics to prevent infection of these foreign objects. Just imagine that there is no surgery because we cannot provide prophylaxis. It's a problem, it's a burden, and people will live in fear of minor infections. I think and I agree that we stand today on a threshold of post-antibiotic era, but we can do something about it. We are sitting on a time bomb, but we can do something about it. We can slow down the arrival of the post-antibiotic world by taking a tiny step to address this overwhelming problem. Let's be responsible stewards. So in summary, I say that health professionals, and in particular medical doctors, are the front line of patient care, and their decisions directly impact the use of antimicrobials. The commitment of the medical doctor to responsible prescribing, education, awareness creation, collaboration with other healthcare professionals, antimicrobial stewardship, advocacy, collaboration is all essential in the ongoing fight against antimicrobial resistance. Thank you very much.
Thank you so much, Dr. Akua Gyimah, for that wonderful presentation. As the presentation was going on, I picked a few linkages or similarities and some peculiarities as well between what doctors' roles are and even what pharmacists' roles are. It will be interesting to hear from the other professional groups. So, ladies and gentlemen, that was Dr. Akua Gyimah Asante. She has spoken to us about the role of the doctor, medical doctor in awareness education, stewardship, collaborative efforts, infection prevention. She started on research and development, as well as a few other areas. If you just joined us, we are on a webinar. We are looking at the role of health professionals in the fight against antimicrobial resistance, and that is quite interesting. Our facilitators are doing a very great job for us this evening. We want to progress and we want to move to the next presenter. But if you have questions, you can note your questions, you can put them in the chat, and then we would be having our facilitators support us to address or respond to your questions. So we are moving then to the perspectives from a nurse, and we would be blessed to have Dr. Mrs. Yaa Obirikorang to give us the presentation from the perspective of the nurse. Dr. Obirikorang is a registered nurse with specialization at the PhD level in clinical pharmacology. She's a fellow of the Ghana College of Nurses and Midwives and has more than 15 years of extensive practice and teaching experience in clinical nursing, clinical pharmacology, medical and pediatric nursing. Currently, she's a lecturer and the program coordinator for the nursing program at the Department of Nursing and Midwifery, School of Health and Allied Sciences, Garden City University College, Kumasi. She has facilitated several sessions in pharmacology, therapeutics, and pharmacovigilance, as well as research methods. So you get a sense of a well-rounded professional in nursing practice. She has research focus in the area of medication adherence and the area of prescription patterns and quality of life of clients. And she focuses on diabetes, hypertension, and other chronic diseases. Dr. Obirikorang or Obirikorang, you have the audience, please. Please progress.
Thank you very much, Mr. Moderator, and good evening to all of us. I'm happy to be part of this discussion. My two presenters have done justice to what AMR is, its burden, and the drivers of it. I will go straight and look at the role of the nurse or midwife. I'm standing in for my colleague midwives because we happen to work in tandem with all the other professionals. So this is the outline of my presentation. I'll do a quick introduction and we'll look at the role of nurses and midwives in preventing AMR, and I will conclude. So nurses and midwives. We are integral parts of the healthcare team, and we play a major role. Though sometimes some of us would think that nurses and midwives are not in direct have direct roles in AMR. We spend a lot of time with our patients. We are with the patient 24/7. We get to know the progress of the patient's condition. We get to know their problems. We get to know how they are doing, and they easily share their issues with us. And so for us as nurses and midwives, we have a critical role to play when it comes to antimicrobial resistance. And I will attempt to take us through our roles and responsibilities and how we contribute significantly to AMR. Our roles are multifaceted because we happen to be with the patient all the time. We are able to advocate for the patient as well. And so we'll go through the various roles and we'll see how the roles are. So for nurses and midwives, one of the main things that we do, one of the key things that we do is to ensure infection prevention and control. We need to take a look at what the protocol says and ensure that we are doing the right things at the right times. So for nurses, one of the key things that we do ourselves, encourage the healthcare team to also do, and also our patients to do, is proper hand washing. Proper hand washing that can help break the chains of the transmission chain of infections. And COVID has taught us, when we instituted hand washing stands at various places, we realized that it really helped. And for us as nurses, one of the things that we do is to ensure proper hand washing. In addition to that, the use of personal protective equipment, the masks, the gloves, the various types, making sure that we use them when we need to use them. Make sure we take care of our patients where we need to use aseptic techniques. We do that, and all of this go a long way in preventing the spread of infection and reducing the need for antibiotics, and by doing so, reducing antimicrobial resistance. In addition to that, we need to take a good look at disposal of waste in our various facilities. And as nurses, we play a key role in there as well. In addition to the infection prevention control roles that we play, nurses, we are patient advocates in and we educate patients all the time, from by educating them on their diseases, educating them on their medications, and then also advocate that the right antibiotics are used for our patients all the time. When it comes to education, we educate them about not sharing antibiotics. Some of our patients tend to do that. So they visit the hospital, they go through, they see the prescriber, they get some antibiotics prescribed for them for an infection, and they go back home. When their colleagues or friends or family members fall sick and they present with similar symptoms, they tend to share the antibiotics, and that can go a long way in causing AMR. So we educate them not to share their antibiotics. We also educate them to complete the full course. If it's for 3 days, if for 5 days, 10 days, they need to complete the full course, not stop when they start experiencing some improvements in their condition. So they need to complete the full course, adhere to the treatment. If they are supposed to take it with food, without food, if they have to take it twice a day, 12 hourly, 8 hourly, whatever the instructions are, they need to adhere and complete the full course. Then another thing that we educate them on is not to pressure prescribers for unnecessary antibiotics. So we have some of our patients, when they come to the hospital, they have some ideas, some already formed ideas that they want this particular medication. They think what they have is an infection, so they need to be treated with antibiotics. And when the prescriber even goes to the point where they tell them you don't need an antibiotic for this particular infection, they go on and put a lot of pressure on the prescribers. So as nurses, we educate them not to put pressure on prescribers so that they prescribe antibiotics for them when they do not need the antibiotics. So these are a few some of the things that we would educate the patient on, and then we also advocate for the patient. When the patient does not need an antibiotic and it is prescribed, or the dose that is prescribed, or the frequency or the duration, if it needs to be clarified, we do that in an attempt to advocate for safe antibiotic use in our patients. Then, when the prescribers give their orders, we, the nurses and midwives, we are the ones who administer the drug. We also monitor the patients. We monitor the patients for the therapeutic effects of the drugs. We also monitor for adverse reactions, complications that may arise out of the antibiotic use. And so for us as nurses, we are trained to be responsible medication administrators. We observe the rights, the 10 rights, before we administer the medications to our patients. And then also we monitor the patients. We report on the therapeutic effect is actually being achieved. If it is not achieved, what can we do? Can we do a timeout review the treatment that the patient is on with the prescriber, and then is there the need to do a culture? We would have to do that. Then when it comes to the administration as well, before we start, ideally before antibiotics are started for the patient, we need to take, if there is a need for a culture and sensitivity, we need to take the sample before we start the drug administration. And so we are taught how to take the samples before we start it, how to take samples that will not be contaminated, and will get the appropriate results for our patients. And in addition to all of that, when the results come in and the prescribers are aware, are made aware of the results, and there is a need to change the antibiotics, we are right there to assist and help in the administration of the new antibiotic. Then we have a role to play in antibiotic stewardship. For us as nurses, our roles there is to work with the multidisciplinary team to optimize antibiotic use, and then also ensure that the right antimicrobial agent is prescribed for the right patients at the right doses, and then also for the right duration. So we are there with the with all the team members who are supposed to ensure antibiotic stewardship. And with that, we play a pivotal role, and because we are with our patients all the time, and we are able to communicate the information, the condition of the patient. If there is a change, we are able to communicate and collaborate with the healthcare team to ensure and that the patient receive the right medication, and also we need to make sure that we are responsible when we are prescribing antibiotics. We are there to advocate for the patient. And so with collaboration and communication, we work closely with all the members of the healthcare team to ensure a coordinated approach to the patient's care that will prioritize responsible and rational antibiotic use. And in addition to that, you cannot continue practicing if you don't continuously improve on what you know. And so for nurses and midwives, as part of the continuous education that we receive, we go through several discussions and workshops on antibiotic use, new antibiotics that are in, best practices that are in. We go through all of that, and then we are able to ensure that the patient gets the right antibiotic for the right condition. And then also, not just the antibiotics, education, continuous education about the antibiotics themselves, but the techniques involved in administering the antibiotics too. We need to ensure that we receive the necessary education so that we can ensure that our patients get the safe and quality care that they need. We also have a role to play when it comes to surveillance and reporting. So when our patients come on admission, we take a lot of data from them. In addition to the data that we collect from them, we ask a lot of questions. Whilst we are collecting these data, we ask a lot of questions regarding their recent antibiotic use, about allergies, so that we can ensure that the team, as we collaborate with the healthcare team, we provide this information and it is duly reported locally in the hospital, and then where necessary, to the national level, up to the national level as well. Then we have also a role to play when it comes to the reporting. We need to report on adverse reactions when the patients um, are on the antibiotics or antimicrobials. We need to report. We need to understand the potential interactions that are there, and make sure that we report any one that our patients experience. Then we need to also take part in local and international research, so that by collecting data as well, so that we can provide the necessary information that our patients need. Then we also need to track the prevalence of AMR, and this will help in guiding public health responses when there is the need to respond. We also have a role to play when it comes to advocacy and policy support. And I hope that some of my colleagues or senior colleagues or nurses or midwives are part of the team that developed the policy documents on AMR. So there, we advocate for policies and then practices that will combat or prevent AMR. We participate in discussions just as we are doing locally, nationally, and internationally, to promote responsible antibiotic use and make sure we have better resources to work with when it comes to infection prevention and control. And as nurses, we also always engage in community work where we educate the patients. Usually, we have strong connections with the community members, and so it's easy for us to educate our patients, our community members, on antibiotic use, safe antibiotic use, and on not putting pressure on prescribers, how to keep the environment clean, so that we are able to, at every level, provide the necessary education to the public. This community engagement can be a powerful tool in reducing the demand for unnecessary antibiotics, because when the community members, they know the consequences of putting this pressure on the prescribers to prescribe antibiotics just so because they feel that the condition they have they need antibiotics, when there is that engagement with the community members, we can reduce the demand for unnecessary antibiotic use. So, in conclusion, nurses and midwives, we play an important role in combating antibiotic resistance, with our duties extending beyond the bedside to the larger healthcare system and the community. We do this through education, infection prevention and control, responsible and safe medication administration, collaboration, and contribute significantly to the fight against AMR. And we are right there to ensure that there is preservation of effective antibiotics for the future generation. So thank you, and I hope that we have all learned a lot. Let's keep up the collaborative efforts to ensure that antibiotics are safe for our patients.
Thank you so much, Dr. Yaa Obirikorang, for that presentation, brilliant presentation, and congratulations for the excellent delivery as well. Because of time, I would quickly want to take the next presentation so that we get some time to do our Q&A, our questions and answers. If you have questions, you can put them in the chat or you can note them and then we will address them. So for our next speaker, he will be speaking from the perspective of the biomedical scientist, and then he will be addressing the same issue around the role of health professionals in the fight against antimicrobial resistance. He is a medical laboratory scientist himself, an astute one. He has been around working for the past 32 years, holding several positions in the sector. He is currently the chief medical laboratory scientist and head of clinical laboratory unit, institutional care division, Ghana Health Service. He is MLS Mills Papo, or William Ado Mills Papo, MLS for medical laboratory scientist. And he's an accredited auditor of the African Society for Laboratory Medicine, ASLM. And he also served as the regional biomedical scientist in the Volta region for 12 good years. He has a master's degree in hematology from the University of Westminster, London, and a certificate in health administration and management from our own GIMPA, Ghana Institute of Management and Public Administration. His accolades are many, but he has also several publications, some of which are worth mentioning: the role of glutathione in defense against nitrosative stress in erythrocytes. And you can see that the trend of his publications are around white blood cells and all of that. He's done some work in implementation of human leukocyte antigen testing in Ghana and a host of others. This is an astute professional in the area of lab medical practice, and we want to welcome Dr. William Ado Mills Papo. Doc, you have your audience and you can do your presentation. Thank you so much for coming.
Okay, thank you. I'm grateful for the presentation. Okay, so I can go through the slides. Thank you. I think as the other presenters have presented, we have similar presentations to help in the combat against the AMR battle. So let's look at what the biomedical scientists, the role that the biomedical scientist or the medical laboratory scientist plays. Okay, so my presentation outline will look at a brief introduction, the role of the biomedical scientist or the medical laboratory scientist. We'll touch a little bit of diagnosis since I have only 10 minutes. Then some slight bit of research, public health. Then we'll look at the One Health approach, and we can conclude very well. So as a form of introduction, let's all imagine we are in a world where infectious diseases in living organisms are impossible to treat. This scenario could become a reality as microbes develop resistance to the medicines we use to combat them. Very, very serious indeed. So globally, antimicrobial resistance is a major public health threat. World Health Organization has declared this as one of the top 10 global public health threats facing humanity. It is estimated that about 10 million people will die per year by 2050, with a total global cost of $100 billion US. So just imagine. Please, next slide. So with the discovery of antimicrobials, many diseases causing organisms were no longer deadly or a deadly problem. However, with the overuse, misuse of antimicrobes, the spread of resistance is deteriorated by scientists are medical detectives. So we are detectives in the healthcare settings by analyzing biological samples in all fields. You can talk about hematology, you can talk about microbiology, histology. And then we collaborate closely with clinicians, pharmacists, and other healthcare providers. So the collaboration is strong. So the threat of microorganisms such as bacteria, parasites, and viruses is a great public health concern. So we are all worried if we don't do our things well, especially to combat the micro AMR situation. There will be methicillin-resistant Staphylococcus aureus, resistant artemisinin-based combination therapies, drug-resistant HIV strains, and all will come into play. So so we'll look at the role of the medical lab scientists in the AMR battle. So if you look at the diagram, you'll be able to see that we play many roles in the diagnosis, public health, research, and in One Health. So if we want to look at diagnosis, see that the medical lab scientists will provide accurate diagnosis results by isolating and identifying the specific pathogens causing infectious or their associated biomarkers. We look at it to confirm or rule out the causes of specific infection, which guide healthcare teams in prescribing targeted treatments. So MLS perform tests to determine the susceptibility of microbes to various antimicrobials. So we do culture and susceptibility testing, and this helps clinicians to choose the most effective treatment. This precision minimizes the unnecessary use of antimicrobials, curbing the development of resistance. So for instance, medical lab scientists stay updated on the latest advancements in diagnostic technologies and treatment strategies. We carry out the following activities. So first, we carry out quality assurance in diagnosis. We implement quality assurance measures to ensure the accurate and reliable diagnostic tests by regular calibration of equipment, proficiency testing, and adhering to standard procedures. We also look at point of care testing. So you can see there, you see the point of care testing is also there. We detect infectious and determine appropriate antibiotic treatments directly at the patient's bedside. That's the point of care testing. Then the medical lab scientists also ensure that test results are interpreted correctly and guide appropriate treatment decisions. We will also detect genetic markers associated with antimicrobial resistance by identifying specific resistant genes in microbes, which help in a more targeted approach to treatment. So specific resistance genes, which help in a more targeted approach to treatment. Medical lab scientists also perform advanced techniques like whole genomic sequencing. So we do whole genomic sequencing and bioinformatics to analyze the entire genome of pathogens. So this enables a detailed understanding of the genetic basis of resistance and aids in the development of targeted therapies. We also perform drug titration. You see, so drug titration to determine drug concentration in serum when the difference between the effective dose and therapeutic dose is very narrow. So if you have very narrow difference between the effective dose and the therapeutic dose, we have to do titration. Example, insulin, anticonvulsants, sedatives, blood thinners, and antidepressants. All those things we do titrations to. So let's move to research. When it comes to research, what do we do? So when it comes to research, you can see that medical laboratory scientists carry out the following under research. We evaluate antimicrobial activity in microorganisms and support to implement antimicrobial stewardship programs, thus promoting the responsible use of antimicrobials. So you can say that informatics, we also help in screening thousands of synthetic and natural compounds to identify those with antimicrobial properties in developing new drugs. Okay, so in research also, we develop new diagnostic tools and technologies enabling faster and more accurate identification of pathogens and their resistant profiles. Then we take global health initiatives by sharing data. So we take global health initiatives by sharing data, participating in collaborative research, and supporting international guidelines for antimicrobial use. Of course, we use bioinformatics tools to analyze large data sets to identify trends. So we identify trends, patterns, and clusters of antimicrobial resistance, leading to the early detection of emerging and re-emerging resistance patterns, which enables timely interventions. So this awareness enables timely adjustments to treatment protocols and helps in predicting future trends. Wonderful. So all this will help us also to predict future trends. So actively participate, that is MLS also actively participate in research initiatives, contributing to a better understanding of antimicrobial resistance dynamics. You see, so development of rapid diagnostics, enabling quicker initiative or initiation of targeted antibiotics therapy. So I think this is what we do in research, very broad and very, very, very interesting. So when we come to public health, we look at biosafety and biosecurity. We also look at public health or the public education, then infection prevention and control. We also look at the epidemiology investigation. So let's look at the roles we play there. So the role of medical laboratory scientists is critical in public health interventions to prevent the spread of antimicrobial resistant pathogenic organisms. So MLS assists in infection prevention and control, IPC, by actively contributing to surveillance programs for nosocomial or hospital-acquired infections, helping to identify and control the spread of resistant pathogens. We also adhere very strictly to biosafety protocols to prevent the accidental release of resistant organisms into the public domain, reducing the risk of laboratory-acquired infections. We also go ahead and to engage in biosecurity. So now we have biosafety, preventing ourselves from getting the infection. Then we have biosecurity also, preventing the organisms from going out to cause havoc. So MLS engage in biosecurity and biodefense activities, ensuring preparedness for potential biological threats by creating protocols and implementing high surveillance measures. Essentially, we engage in educational initiatives such as continuous education and training within the MLS community. We also actively contribute to antimicrobial stewardship and promote responsible antimicrobial use, emphasizing the importance of optimal dosage and duration. Medical laboratory scientists also educate healthcare professionals about the importance of proper specimen collection, testing, and interpretation of results to guide appropriate antimicrobial therapy. So the microbiology laboratory is an essential part of effective infection prevention and control, IPC. Medical lab scientists help to raise awareness about the responsible use of antibiotics. They educate communities about the consequences of misuse and the importance of completing prescribed courses of antibiotics to curb resistance development. Medical laboratory scientists go ahead to conduct epidemiological investigations of infections or of infectious diseases by identifying the source. We identify the source, transmission dynamics, which is important for preventing the spread of resistant strains. And last but not the least, we also conduct surveillance activities to monitor and analyze data on antimicrobial resistance patterns. This information helps healthcare providers and public health agencies understand the prevalence of resistance in particular region of the community. So let's look at the One Health approach. So let's go to the One Health approach. So in the One Health approach, medical lab scientists is very, 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 very pivotal in the One Health approach by collaborating with veterinarians. So veterinarians, we collaborate with them in the animal side to monitor and control antimicrobial resistance in animals' environment health or environmental health. We also look environmentally, MLS monitor antimicrobial residue in water and soil and resistant bacteria in water sources and soil, contributing to a holistic understanding of the factors contributing to resistance. So in conclusion, so this is all the One Health approach. These pictures is that we look at the human environment and the animal side. So let's go to the next slide. So go into the multifaceted treatment decisions and public health strategies aimed at preserving the effectiveness of antimicrobials and of antibiotics. So this ends my presentation. You can see the role of medical laboratory scientists is very, very crucial in the fight or the battle against AMR. Thank you very much. Thank you very much.
Thank you so much, Dr. Papo, for that brilliant presentation. He adds other dimensions to the role of health professionals when it comes to the perspective of the biomedical scientists. Thank you so much. Of the role of healthcare professionals in the fight against antimicrobial resistance. This is where we get to interact with our panelists and our facilitators. We would start right away with a series of perspectives so that if you have your questions, you can also share with us, and then we would ask them, and our facilitators would also help us to give responses to all of them. So I want to start at their perspectives on the subject matter that we are looking at the moment. Now, as you were presenting, I could tell that you touched on several areas. You spoke about awareness creation and education that are available to in terms of being able to fight AMR as professionals. And we want to take turns from the presenters. So we still go first with Mr. Yevutsey, after which we would then go to Dr. Akua Gyimah, and then Dr. Yaa Obirikorang, and then Dr. Mills Papo, in that order. So what are some of the tools available to us? I'm a health professional. I'm working in a remote area. I'm working in an urban area. What really do I have to work with? What are the tools available to us in this fight against AMR? Dr. Saviour, Mr. Saviour, you have the floor to start with.
Yes, so thank you very much. So as health professionals, we have so many tools that we can deploy to first, what do we want to achieve? Is it that we want to raise awareness about the menace, the resistant issue? So there are enough evidence now in country based upon which we can couch our messages and tell the patients or our clients. That's so I'm talking about enough evidence available in the system for us to have our messages for education. We also have a lot of educational materials available. If you go to WHO website, there are so many of that. And then we also have at the AMR Secretariat, we have some flyers that will be using educational materials that we can use to educate our clients at the facility or at the community level. There are opportunities even at the hospital settings where we have this OPD education that takes place all the time. So we can have that tailored, use that opportunity and have messages that we want to communicate with our clients. And these are some of the tools or the opportunities that are available for us to use. And we have to give chance to the other facilitators to mention the rest. Thank you.
Thank you very much, Brian. I think I'll go ahead with my suggestion regarding tools that will enable us to play our roles. I believe that fundamentally, wherever we find ourselves, we should begin to set up antimicrobial stewardship committees and teams. And that will be the basis, the foundation for antimicrobial stewardship in that facility. Once people who are passionate about it are given the opportunity to join the team, they must be given clear terms of reference so they know what they are expected to do and not just be in the team, but they should be given clear terms of reference. I think the antimicrobial stewardship team is a good foundation as a starter. And like Saviour said, we have available resources. We need to read and improve our knowledge on AMR and AMS. Like I said, is very dynamic, and every now and then there's some new emerging issues regarding AMR. So we need to improve our knowledge on an AMR. We have a whole AMS directorate in the Ministry of Health. We can collaborate with them to give us some guidelines. But we also have access to the internet. We can read on the aware classification, GLASS. We can read on all the resources that can empower us to know the modern trends in antimicrobial resistance. And I think that we also need to also develop our research skills so that we can participate in AMR surveillance and also be able to interpret our data and use that to inform policies. And I think the one important tool we can use is communication and collaboration. We need to form formidable teams that are well-versed in AMR issues so that we can push the agenda forward. Thank you.
So we can take
okay.
Dr. Obirikorang, you can go.
All right. Thank you very much. In addition to what my senior colleagues have said, I believe that we can even start in our various wards and units and our hospitals. We have a lot of protocols that are available to us when it comes to infection prevention, how to manage infections. We have the Ghana Standard Treatment Guidelines. It's also available to us in our various facilities. So we can quickly access those ones, even if we don't have access to internet. But just as Dr. Kywiaa said, all of these, you can find resources on the internet. Let's read. We can read articles that are published in reputable journals. We can also look at the policy documents that are available so that we can keep abreast with this ever-changing AMR situation that we all find ourselves in. Thank you.
Yeah, so Mr. Papo, you are next.
Yes, so as they have all said, we need to use the appropriate tools available. For instance, when it even comes to Ghana Health Service, we have the health promotion there. Health promotion, we should collaborate well with health promotion, Dr. Abaje da Costa and his people to be able to, share or distribute educational materials. We can have videos and other educative or educational materials even at the hospitals, so that whilst patients are waiting, they are waiting for services, they can also, some of those things can also guide them. But when it comes to investigations, yes, we need to, now we are talking about network of practice, we are talking about hubs and spokes, we are talking about different levels of healthcare. And microbiology, culture and susceptibility testing, we know it's not done at the lowest level, at the health centers, and even most of district hospitals are not doing it. So I think we have to raise awareness, we have to make sure we have educated people, we have medical lab scientists at most of the levels. So as we are even in Koforidua now talking about network of practice and other things, diagnostic network optimization, I think we have to use those tools. Also to make sure that lower facilities which cannot do those things, we have hubs and spokes. The spokes can collect samples, sample referral system, and then send them to the higher facilities where we can do those investigations. So I think in a nutshell, we can use these tools also to help us in the fight against anti-AMR. Thank you very much.
Thank you so much, our facilitators. for your perspectives on all the tools that are available to us. Now, I want to zone into a specific area now in terms of what some of the practical opportunities are for working together as a team. I mean, we ask because really, if you look at what you have presented, a quick analysis will tell us that there is a lot of commonalities. Okay, we all do some form of IPC, we all do some form of advocacy, we all do some form of education and awareness creation. We are all doing some quality assurance and all of that, meaning that there are really opportunities together. But how practical are these opportunities? From your experience as professionals, how can we work together as a team?
Yes, so one of the platform that we think we can utilize much is the antimicrobial stewardship at the facility level. Even we are even talking about it at the community pharmacy community level now. The stewardship is where we have all the expertise at the hospital coming together, charting a common pathway, and set a target for themselves that they want to do A, B, C, D. For instance, if they've all agreed that they want to uh, reduce nosocomial infection or healthcare associated infections, so all the activities they want to do, put their strengths together, I think that is the one of the opportunities that we have, creating or setting up antimicrobial stewardship at the facility level. It's one of the tools that we can use as a means of collaboration to fight against AMR. Over.
Thank you so much, Saviour. Can we have Dr. Yaa Obirikorang give us some perspectives? And then Dr. Gyimah, you can also come in.
All right, thank you very much. I want to share a very practical experience that I have been involved in. So for the hospitals that I have worked as a clinical nurse, we have had this, what we used to call back then, general ward rounds. And this had the medical doctors, it had even the hospital director, part of it in one hospital. Yes, even the second hospital. The medical director themselves, they were there. And then we had the nurses, the doctors, the pharmacists, and then also the medical laboratory scientists. At a point, there was even a dietitian and all that. So we go and attend to the patients from bed to bed. We would look at the diagnosis, the differential diagnosis, the medications they are on. The pharmacists will bring out their perspectives or what they think the patient should be receiving. The medical laboratories technologists so would also come in and tell us, okay, we should have done maybe a culture and sensitivity. We do a review of the medications that the patients are on. If we realize that, oh, the patient has been on it for, let's say, 48 hours, 72 hours, we are not seeing any improvement. And this we can easily observe from the monitoring that the nurses were doing. And we will just there and there collaborate, discuss, and sometimes we will stop the medications they are on, wait for a couple of about 24 hours, don't put the patient on any medication. Then we do the culture and sensitivity. We get to know which antibiotic will work in that instance and then put the patient on that antibiotic. And the periods that we happen to do this, it really helped our patients. They stayed less, the period that they stayed in the hospital reduced. We had one patient, we were fighting. I mean, we were fighting some form of infection. Almost every time this child will be coming to the hospital. But when we had that holistic approach and we looked at a patient's condition, we were able to help the infection should I say, there was a cure. So for a practical situation, we need to collaborate. Yes, there are times that there are small conflicts here and there, ego issues, but when we look at what we want to achieve for the patient, it really works. The general ward rounds, or I don't know the names that some hospitals will call it, but it really worked for us. Thank you.
Thank you. So, Dr. Gyimah, you can have the advice. Dr. Gyimah, I don't know if you are muted. I couldn't hear you.
Sorry, I think I was muted. Can you hear me now?
Yes, we can. We can hear you.
Okay. So I was saying that in order to make practical the fight against antimicrobial resistance in the hospital, fundamentally, there is a need for us to establish antimicrobial stewardship teams and committees in all the facilities. And like I said, it must include all cadre of staff. It must include doctors, nurses, pharmacists, laboratory scientists, even biostatisticians, crucial health information officers, community health nurses. They must all come together to form the antimicrobial stewardship team. And then with clear reference, terms of reference. I also think that these teams must have a strategic plan or an action plan that spells out all the activities that they have to embark on to attain their targets. And that includes the AMR ward rounds, the GPPS I talked about, the laboratory surveillance. So within the group, we know that maybe the medical laboratory scientist will take active control of the AMR surveillance, while the pharmacist will be involved in global point prevalence survey, while the nurses may lead the infection prevention control and delayed prescription as is seen in my facility. And then the medical officers, together with the medical laboratory scientists, the pharmacist, will also perform the AMR ward round. So if everybody has a role to play in the team, everybody executes, and together we work and make sure that we attain our target. And it should be institutionalized such that it doesn't go away with one person, maybe one person leaving the facility, and then the whole stewardship program dies. It should be institutionalized. And in institutionalizing it, we have to make sure that we have frequent meetings. The AMS teams have frequent meetings to look at their action plan and then monitor and evaluate what they have been doing. Thank you.
Thank you so much. At this point, ladies and gentlemen, we want to take some of the comments and questions from participants. In fact, the questions are trickling in. There are lots of them, but we'll only be able to respond to a few. So I can tell that this question will be of interest to Saviour. The STG has been mentioned, and therefore, when is the next edition coming into circulation? The question is that the current edition has outlived its usefulness. Most of the treatment options are not adhered to. Saviour, hold on that question. There's another question about how can community pharmacists be trained and empowered to ensure AMR stewardship? We get a lot of requests for antibiotics. So Saviour, you can add those two questions and address it in your response. Then we have a question on empirical treatment, and empirical treatment having to do with how empirical treatments can promote AMR. And I don't know if Dr. Gyimah can look at this for us, and then you can also address it from the pediatric perspectives as well. Then we have another one on how can IV antibiotics be used when parasite level is high in treatment of malaria. And this one, I leave it for all of you. Anyone who is inclined to respond to this, you can. The question is, can you please add IV antibiotics when parasite level is high in treating malaria? And then we can then also have, maybe Dr. Papo can also look at this for us. How often are hospitals fumigated? And then what is the role, or what role does the AMR office and often the Ghana Health Service is Ghana Health Service monitoring the fumigation of facilities? That's what he's trying to ask. So, Dr. Papo, you have the fumigation and Ghana Health Service monitoring of fumigation. Anyone can take the issue about antibiotics, IV antibiotics, and malaria. Saviour, you are addressing the issue of the STG and community pharmacists and their role in antibiotic resistance. So, panelists, you can give your perspectives. And because this is going to be our last round, if you make your comments, you can add your concluding remarks, and then we will not come back to you again. So, over to you.
So, thank you very much. With the issue on the STG, yes, the STG is under revision as we speak. Some sessions have been completed. When it comes to the antibiotics, we are gathering evidence on some new molecules that are likely to enter into the standard treatment guideline. A decision has been made that there's the need for us to have some reserve antibiotics to be added to the STG. So the question is, when is the new one coming? We are working towards next year. Maybe by middle of next year, we should be able to conclude the revision process and then have it launched. We are also thinking about digitalizing the STG this time. So when we get to that stage, we'll be engaging all stakeholders. And I know some of you online now will be joining us at those stakeholders meeting. When it comes to the AMS at the community level, yes, if you could see, even at the facility level, we are still piloting the antimicrobial stewardship programs. But some achievement have been made in that regard. So now we are the rollout phase. But for the community pharmacies, there is a program from the CW Pharms on the involvement of community pharmacies in antimicrobial stewardship. So this will be the first of its kind. So it will be a pilot based, and lessons that we learn from there will help us to roll out nationwide. So I would say that there are big plans to pilot AMS at the community pharmacies. I think that then to talk about the parasite, if the diagnosis is malaria and that the parasite concentration is very high, it does not turn into antibiotic bacterial infection unless there is evidence that there is bacterial infections. Yes, they could use the antibiotics, but I will leave that also for my other colleagues. My concluding remark is that, in fact, I want to appeal to all health professionals, including myself. Let us increase our commitment in the fight against AMR. If we don't do that, these small bacteria will trouble us. Thank you, and over.
Dr. Gyimah, you have the floor, but I think you're muted.
Okay. I will try and answer the question about empirical treatment. So empirical treatment has a place in the treatment of critically ill patients. But the most important thing is that before you do empirical treatment, you need to take your samples for cultures so that you can look at the culture results for targeted treatment. Once your culture results comes in and your culture is most likely the organism that is causing the infection, then you switch to targeted treatment. So for people who are very ill and will need some form of antibiotics, you can go ahead and look and give empirical treatment while you do your cultures. And once your cultures come in, you switch to the antibiotic that is more likely to kill the bacteria. Now for hyperparasitemia, you would usually hyperparasitemia will cause severe malaria, and you would give IV artesunate for the malaria treatment. It is only when you think that you are not sure about the definite diagnosis, you're not sure whether it's cerebral malaria or meningitis. When you are thinking it could be meningitis, then you are at liberty to start your IV antibiotics, but then you will have to take your samples, like I said, do your lumbar puncture, take your CSF, so that you can look for any organisms in the CSF. And if it is indeed meningitis, then you can at least continue with your full treatment for meningitis with IV antibiotics. Thanks.
Great. So thank you so much for those perspectives. Dr. Obirikorang, your perspectives are also welcome.
All right. Thank you very much. There was a question about the 10 rights that we follow when we used to administer medications to our patients. So the rights are the right drug for the right patient in the right dose, through the right route, using the right technique, at the right time and frequency. The patient also has a right to refuse, and the nurse also has a right to refuse if the order is questionable, looking at using her clinical judgment, and then also looking at the patient's condition. The nurse has a right to refuse to administer an order like that. Then there is also the right for drug interactions and evaluation. So that is why we have to know about possible interactions and then how to evaluate or monitor the patient. Then also there is the right to take the history and then do an assessment for the patient before you administer the medication. Then we have the right documentation of the medication that is administered, and there are a lot of things that we would document in there. Then there is the right for the patient to be educated and given the right information about the medications that they are on. So we follow these rights, and anytime we go against any of them, we are likely to cause a medication administration error, and that may be harmful to our patients. So with my concluding remarks, I would say we should all collaborate as health professionals to combat AMR, because if we do not collaborate, we are already sitting on a time bomb, so it would escalate and cause more trouble for all of us. Let's engage in continuous education as professionals so that we know the new trends and know how to appropriately respond in any health situation. Thank you very much.
Thank you so much, Dr. Obirikorang, for that. And on the issue of rights, I know that Dr. Yvvonne Esseku has a right to close us for the session and bring all proceedings to an end. I hand over. Thank you for your time on the session as Dr. Yvvonne takes over in her rights as the key focal lead person for this. Over.
Thank you so much. Thank you very, very much. So I think, first of all, I have to say thank you to the WHO for supporting us to bring this session, this webinar to you. Yes, we have run out of time, but give me just a few minutes to give you my concluding remarks. Wow. Well, it is Wow Week, and wow, AMR is a troublemaker. That it is more than it is causing us more trouble, probably likely, than malaria, is something that we should all be concerned about. Who would have thought that would be the case? But that is it. And now we are told that by 2050, if nothing is done, but we are here and we have learned and we have heard what we as healthcare professionals can do, how we can collaborate. We have also heard about the tools and opportunities that are available to us. There are education materials. We can form AMS teams. There are resources available, policies, documents, and we can collaborate. So let's keep ourselves abreast with the current trends, because new information is coming all the time, and it's important that we are aware of what we are doing. And let's seek out opportunities for collaboration among ourselves as healthcare professionals. We know from the experience that has been shared that improves patient outcomes. And we could be, in fact, we are tomorrow's patients. Let's each of us put our shoulders to the wheel. That way, in 2050, it will not be said that nothing was done, but rather that something was done. And as a result of that, the potential gloomy future was averted. Remember, we need you. And thank you once again for joining. Let us take all the tidbits that we have learned, the things that maybe we knew already and we have been reminded of. Let's take them all. Let's apply them to our work and our lives. And let it be that in 2015, the story will be a positive. 2050, the story will be a positive one. Thank you so much for joining. And thank you once again to WHO for supporting us. I'll hand over back to you, Brian.
Well, thank you so much. And Jedidah, I don't know if you have some comments, some inputs at this stage, but this is where we draw the curtain. We thank you for your participation and then staying with us all through. We hope for the best in terms of the next sessions that will come. We keep the communication lines open, and then thank you, and then have a good evening.